Hello and welcome. We will continue where we left in previous part. The learning objectives of this multi-part lecture are listed here. Please take a look. The viral hepatitis is a potentially life-threatening infection, especially hepatitis B and C, which are the topics in this lecture. They are treated with drugs which target nucleic acids and also with interferon, especially its long-acting form with PEG attached to it. The advantages of nucleoside or nucleotide analogues therapy of hepatitis over interferons include fewer adverse effects and a one-pill-a-day oral administration. The main advantages of interferons over nucleoside or nucleotide analogues includes a finite duration of treatment, the absence of resistance, and achievement of higher rates of viral agglutinin reduction. However, the disadvantages of interferons are that less than 50% of persons treated will respond, its high cost, administration by injection, and common adverse effects, which preclude its use in many persons, particularly in resource-limited settings. Moreover, there are many contraindications for the use of interferon. Interferons are host cytokines that exert complex antiviral, immunomodulatory, and antiproliferative actions. Interferon alpha appears to function by induction of intracellular signals following binding to specific cell membrane receptors, resulting in inhibition of viral penetration, translation, transcription, protein processing, maturation, and release, as well as increased host expression of major histocompatibility complex antigens, enhanced phagocytic activity of macrophages, and augmentation of the proliferation and survival of cytotoxic T cells. Interferon has a short half-life requiring repeated doses. Pegylation, which is the attachment of polyethylene glycol to a protein, reduces the rate of absorption following subcutaneous injection, reduces renal and cellular clearance, and decreases the immunogenicity of the protein, resulting in a longer half-life and steadier plasma concentrations. The longer half-life would result in once-weekly dose and avoid suffering of the patient due to adverse effects, especially a flu-like syndrome. Pegylated interferon is used to treat both hepatitis B and C as well as some malignant conditions. The adverse effects of interferon alpha include a flu-like syndrome, i.e., headache, fevers, chills, myalgias, and malaise, that occurs within 6 hours after dosing in more than 30% of patients. It tends to resolve upon continued administration. Transient hepatic enzyme elevations may occur in the first 8 to 12 weeks of therapy and appear to be more common in responders. Potential adverse effects during chronic therapy include neurotoxicities, mood disorders, depression, somnolence, confusion, seizures, myelosuppression, profound fatigue, weight loss, rash, cough, myalgia, alopecia, tinnitus, reversible hearing loss, retinopathy, pneumonitis, and possibly cardiotoxicity. Induction of autoantibodies may occur, causing exacerbation or unmasking of autoimmune disease, particularly thyroiditis. Contraindications to interferon alpha therapy include hepatic decompensation, autoimmune disease, and history of cardiac arrhythmia. Caution is advised in the setting of psychiatric disease, epilepsy, thyroid disease, ischemic cardiac disease, severe renal insufficiency, and cytopenia. Alpha interferons are abortifacient in primates and should not be administered in pregnancy. There are multiple drug interactions. Here is an algorithm to treat hepatitis B infection. Take your time to explore it. No specific treatment is available for the treatment of acute hepatitis B infection, which most often resolves spontaneously. The goals of chronic HBV therapy are the suppression of HBV DNA to undetectable levels, seroconversion of HB-Ag, or more rarely, HB-Zag, from positive to negative, and reduction in elevated serum aminotransferase levels. These therapeutic endpoints are correlated with improvement in necroinflammatory disease, a decreased risk of hepatocellular carcinoma and cirrhosis, and a decreased need for liver transplantation. Cure is rare. In addition, because current therapies suppress HBV replication without eradicating the virus, initial responses may not be durable. The covalently closed circular viral DNA exists in stable form indefinitely within the cell, serving as a reservoir for HBV throughout the life of the cell and resulting in the capacity to reactivate. Relapse is more common in patients co-infected with hepatitis D virus. Lamivudine inhibits HBV DNA polymerase and HIV reverse transcriptase by competing with deoxycytidine triphosphate for incorporation into the viral DNA, resulting in chain termination. Resistance may appear and limits its use. In that case, adifovir and tenofovir are suggested, although their efficacy is slower to manifest. Although tenofovir and telbivudine are nowadays regarded as the first choice to treat chronic HBV infection, lamivudine remains an important drug. To reduce vertical transmission of HBV, tenofovir remains the drug of choice. The alternatives are telbivudine and lamivudine. All are tolerated well and are suitable for long-term treatment regimen. In contrast to the treatment of patients with chronic HBV infection, the primary goal of treatment in patients with HCV infection is viral eradication. In clinical trials, the primary efficacy endpoint is typically achievement of sustained viral response, SVR, defined as the absence of detectable viremia 24 weeks after completion of therapy. SVR is associated with improvement in liver histology, reduction in risk of end-stage liver disease and hepatocellular carcinoma, and, occasionally, with regression of cirrhosis as well. Late relapse occurs in less than 5% of patients who achieve SVR. Here is an algorithm to treat hepatitis C infection. Take your time to explore it. Ribavirin is a guanosine analog, requires intracellular phosphorylation and acts in multiple ways. A dose-dependent hemolytic anemia occurs in 10 to 20% of patients, usually within the first weeks of therapy. Other potential adverse effects are depression, fatigue, irritability, rash, cough, insomnia, nausea, and pruritus. Contraindications include anemia, end-stage renal failure, ischemic vascular disease, and pregnancy. Sofosbuvir, a prodrug, is uridine nucleotide analog. It was the first-in-class protease inhibitor for use in HCV infections along with other drugs such as interferon and ribavirin. Later other such drugs were developed. These drugs are not used alone but rather in fixed-dose combinations for oral administration. Velpatasvir is available only with sofosbuvir. It is the first once-daily single-tablet oral regimen with pangenotypic activity. No dose adjustment is required for patients with mild or moderate renal insufficiency, or any degree of hepatic impairment. Sofosbuvir exposure is increased in patients with severe renal impairment. Velpatasvir and sofosbuvir are substrates of PGP and ABCG2 or BCRP, both ATP-binding cassette transporters. The most common adverse events in patients receiving velpatasvir, sofosbuvir were headache and fatigue. Thus, the common drug combinations against HCV infection can be listed as shown. This is a summary diagram of all the drugs covered in this multi-part lecture. It shows a list of important antiviral drugs. Which nucleotide analog are they? ATCG, their mechanisms of action, MOA19, top right corner, requirement for intracellular phosphorylation, yes, no, and various viral pathogens. Take your time and learn at your pace. This is the continuation of the previous slide. Please note that it is not a complete table. Learners are advised to refer to the textbook for any additional detail as shown next. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!